So match and arrhythmias due to digoxin toxicity, there is the DC cardioversion is contraindicated in these patients. You have to manage them medically. So now another ECG from a 14 years old male, is a young male and he is on antiepileptics. So now it's better to divide the ECG into two parts. One is the arrhythmia and one is the normal one. In the normal one, get the axis which is normal and there is no other obvious finding except one. If you look at the lead 2, the QT is prolonged. If you just follow this long lead 2, so there is a long sequence followed by a short sequence, then there is a PVC which is on T. So this is R on T phenomenon which resulted in polymorphicity. So polymorphicity in context of long QT is called TORSADES. So the diagnosis for this ECG is TORSADES or polymorphicity. So in this patient, the patient had long QT and we can see the long short sequence which is followed by R on T phenomena. The immediate treatment is DC cardioversion. The mechanism of arrhythmia is triggered, which is early after depolarization. Then we have to correct or look for the potassium and the magnesium. They may ask you for the genes of the long QT, long QT1, long QT2, long QT3 genes, which we will discuss later on. They may ask you for the drugs responsible for the long QT and the drugs which are indicated in long QT. And secondly, they may ask you about the indication of ICD, which we have discussed already. Now moving on the next ECG. So this is a ECG from 57 years old female. She presented with vomiting in the emergency department. Now in the ECG, the obvious finding is these fibrillatory waves. The R in V1 and the axis is left. And interestingly, the rhythm is regular. So the fibrillatory waves in V1, regular rhythm, R in V1, and patient presented with vomiting. So the diagnosis is FH with complete heart block. So this is the only case in which the FH becomes regular is complete heart block. The findings are there is coarse atrial fibrillation, there is a regular narrow junction escape at 60 beats per minute, there is left axis deviation clearly, and the causes for this ECG are digoxin toxicity, idiopathic degenerative fibrosis in a patient with chronic atrial fibrillation. Now, if this patient had digoxin toxicity, the medical management will be digoxin immune fab. The causes for this ECG are digoxin toxicity and idiopathic degenerative fibrosis if the patient had previously the chronic atrial fibrillation. So if this patient had digoxin toxicity, the antidote is digoxin immune fab. So the next question may be asked by the CPSP is, will you go for the PPM? So if there are reversible causes, like in this patient who had digoxin toxicity, there is no need of PPM. So if there is idiopathic degenerative fibrosis, there is a requirement of PPM, and the PPM will be VVI in this patient. So now there is another interesting tracing from Holter's. So this is an asymptomatic patient who is 75 years old, and this was a tracing recorded during sleeping. So the important clues are patient is asymptomatic, is elderly male, and the tracing was recorded during sleeping. So the tracing shows PQRS, 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 then some noise artifacts or vibration artifacts, and then you see here P and QRS. So the underlying rhythm is sinus bradycardia, there is marked bradycardia, and then there is sinus arrest, which is more than 3 seconds. So the diagnosis in this scenario is sinus arrest. So the findings are sinus bradycardia, absence of sinus node activity for more than 3 seconds, are noise artifacts, and the next question which can be asked is, will you go for the device? The answer is big no, because the patient is asymptomatic and this rhythm was noted during sleeping. So what else can ask is the indication of PPM in sinus node diseases, and it's better if you go through the PPM trials like NASH, BASE, UK BASE, MOST, and CTOP, because they can be asked with this scenario. So the next ECG is from a 65-year-old female, and she is asymptomatic. So if you go through from the lead 1, it's positive, negative, the axis is left axis, and again there is a small r, there is Q in lead AVL, then in the precordials there is RBP. So the presence of RBP shows the blockage of one fascicle, and the left axis and small r, deep S, and Q's in 1 and AVL shows the left anterior fascicular block. So the right bundle is the first one which is blocked, and left anterior fascicle which is the second one which is blocked. So this is bifascicular block. And interestingly, you see the PR interval which is more than 200. So the diagnosis in this scenario is bifascicular block with prolonged PR. And the findings which are obvious: right bundle branch block, axis deviation, prolonged PR, Q's in AVL. So they may ask you the association of bifascicular block, which is with both the bradyarrhythmias and with the tachyarrhythmias. Patient may experience AV blocks, may present with the syncopes, and may experience VTs. So if the patient presents with syncope and there is no evidence of AV block or VT, then EP study is recommended in these patients before putting a device. So the next scenario is that of a 27-year-old male who is survivor of cardiac arrest. So again, young male survivor of cardiac arrest. Start looking at the ECG from the limb leads. Lead 1 is negative QRS, positive, the axis is right. So if you notice, there is a notch at the end of the QRS there. And then look at the lead V1. V1 is positive, and the T waves are negative, and again the same notch present here. So with the help of the scenario and the ECG, the diagnosis is arrhythmogenic right ventricular cardiomyopathy. So in this ECG, the obvious findings are right bundle block, right axis deviation, epsilon waves are present there after each QRS, which shows the depolarization abnormalities, and the T wave inversions were obvious, which shows depolarization abnormalities in these patients. Again, they may ask you the trait, which is autosomal dominant trait, and now there are two more autosomal recessive types of the ERBC, which are Nexus and Carvajal syndrome. They may ask you the gold standard investigation, which is the CMR. The pharmacological therapies which can be given in these patients is amiodarone and beta blocker for preventing the further ventricular arrhythmias. In all the channelopathies, don't forget to write the family screening. Family screening is very important. And for the ICDs, like in this scenario, who had cardiac arrest, yes, we will go for the ICD, because he had already the cardiac arrest and it's part of the secondary prevention. And if this patient has recurrent VT despite of the ICD and antiarrhythmic treatment, then this patient should go for the VT ablation. Because in arrhythmogenic right ventricular cardiomyopathy, there are islands of the scars, and these scars are the substrate for VT. So we have an option for VT ablation in these patients. Now the next ECG is from 27 years old male, presented with syncope, and there is family history of sudden cardiac death in the family. So now starting with the limb leads, it seems to be okay, and then we will go to the precordials. Look at the V1. The T waves are inverted and there is J point or ST elevation. So this is COVID type 1. So now relating with the scenario, this is clearly BRUGADA syndrome type 1. So why it is BRUGADA syndrome? Because the patient had syncope. So the patient was completely asymptomatic, then we will write it as BRUGADA pattern. So there is COVID type ST elevation and the T wave inversions from V1 to V3. Again, the trait is autosomal dominant and the gene is 5SCN, in which there is loss of function. So importantly, LONQ3 shares the same gene in which there is gain of function. BRUGADA syndrome is responsible for sudden and unexplained nocturnal death syndrome because most of the deaths reported with the BRUGADA syndrome were during sleeping and in the early morning period. Now, if they ask you about the drugs for unmasking, so currently we have 3 drugs, flecainide, propionamide, and najmaline. And if they ask you for the maneuvers for unmasking, so we have to place V1 and V2 at second and third intercostal space. And associations of the BRUGADA syndrome is atrial fibrillation plus to hang out with the BRUGADA, and usually 20% of the patients of BRUGADA are found to have atrial fibrillation. They may ask the precipitating factors for the BRUGADA syndrome, which are fever, alcohol, cocaine, and the large meals. The only drug available currently is sulfidine, and again, in the management part, family screening should be there, and ICD, as we have discussed, or primary or secondary. So this is an overview of type 1, 2, and 3. In type 1, you can see this is COVID type, 2 and 3 is settle type. There are T-wave inversions, and T-wave inversions are not as common in 2 and 3. And the J point elevation is usually up to 1 millimeter in 2, and in 3 it is less than 1 millimeter. So this is how you differentiate between these types.